The following podcast is part of a certified educational activity titled Command and Control MDS, New Science in MDS Management and Implications for Veteran-Centered Care. Access the entire activity and complete the post-test at peerview.com/HWU860. Downloadable slides and practice aids are also available.
I'm Michael Savona, and I'm here with Dr. Andy Brunner this morning to talk to you about MDS. Okay, I spent the good part of my career where there wasn't really much going on in MDS. We had some drugs approved early in this millennium, and then since, not much. And in the past 3 years, we've had 2 brand new drug approvals, 1 compendium listing approval, and we probably have 2 or 3 approvals pending the next year or so. In addition, we've had a variety of changes to prognostic scoring and classification schema, which are probably worth touching on today, and Andrew will go into some detail about that with you. Low-risk MDS, and we don't have the data from what's happened to survival since the starting with these new drugs that I just mentioned, because they were just approved. But if you look at survival curves 10 years apart, 2006, 2007, low-risk MDS survival didn't really change much. The x-axis is in different units here, but it hasn't changed much, number one. And number two, the patients who have transfusion dependence, they do poor. This is an independent risk factor for poor survival. And in low-risk MDS, as you noted on the things you want to learn in that slide, transfusion dependence and managing it is a real challenge. So we formed the Connect Myeloid Registry several years ago, and now we have mature data, and there's been a number of patients with low-risk MDS that we've studied, and this is to study the natural practice patterns and history of patients with MDS and AML. And what we noted is that the patients with low-risk MDS overwhelmingly presented with moderate to severe anemia. Most of them received supportive care only. And most of them never got acute leukemia. They didn't progress to higher risk MDS, but they died as a consequence to the disease in the low risk. So the anemia, the thrombocytopenia, the neutropenia that occurred with their quote-unquote low-risk disease. So we have a lot of challenges in MDS, and I think those are underscored in the veterans that we take care of. We are working as hematologists with clinics, VA clinics that might be 100 or 200 miles away. We're interacting with the team, and we're dealing with higher rates of alcohol use, liver disease, GI nutritional deficiencies, and heavy metal exposure, which complicate our diagnosis. So today, we really want to heighten your understanding of the factors that inform diagnostic, prognostic, and management plans, and hopefully increase some of your knowledge of the evidence of the new clinical trials, things that have come out in the last couple of years and that are brewing and going up for approval. And hopefully be able to answer your questions as they come in. And I already have like 7 of them, so very much appreciated, and we'll save time at the end for questions. So with that, I'd like to hand the mic over to Dr. Brunner.
Thanks very much. Yeah, it's a pleasure to be here and see everyone here today and talk a little bit about MDS and how we think about it, how that management is evolving given a few changes in the field. So, I think that this patient here, a 75-year-old Vietnam era veteran, comes to the cancer clinic referred by primary care. He's been noted to have progressive but stable anemia, so hemoglobin of 8.5 over about the last 6 months, preserved platelets, preserved neutrophil count. This is a pretty common patient for me to get referred to my clinic. How about you? When do you want to see, when should these kind of patients be referred to hem-onc?
Well, I'm a blood doctor, and that's a blood problem. So, I'm happy to see this patient, and all of us deal with referring internists and family physicians who have different skill sets, penchants, and interest. And I think, on the one hand, I have some internists who only refer to me after they do a very complete workup, right? And then some that they have normocytic anemia, and the hemoglobin's 11.5, and they send the patient over.
Yeah, absolutely. I think you hit a good point that same for me. I'm happy to complete the workup wherever it is in a phase of evaluation. I think some tests need to be thought about for confirming MDS and ruling out other causes, but that can be done prior to referral or can be picked up with me when I see a patient. Do you think about, especially for a VA population, any particular risk factors or causes that you're on the lookout for?
Well, as a veteran of foreign war, this is near to my heart. I'm concerned about these veterans, and I know they're at increased risk. Yeah, I mean, there are some things. I mentioned them briefly in the introduction, but I know you're going to talk about them some more.
Yeah, absolutely. I think that we have a lot more tools in identifying a case of MDS, but they also present some unique challenges. So MDS is characterized, as we know, by having low blood counts, right? You have to have anemia or neutropenia or thrombocytopenia. Often you'll have all three of those. The most common, right, though, being anemia or symptomatic anemia. And then there are other criteria that help say the bone marrow is the cause of that low blood count. So having an increase in dysplasia in the bone marrow, having an increase in blasts, which is basically representative of clonal expansion, or having a karyotype or other evidence of clonality to say this mutated population is why you have a low blood count. And it can be challenging because there are other causes of cytopenias, and sometimes it's not just one thing. So when I meet somebody, I'm usually doing a broad panel, looking for nutritional deficiencies. We were commenting before, the number of times that I pick up on copper deficiency is fairly high. And then other exposures, medications that can be prevalent in patients as they come in with MDS. And sometimes you're not sure if it's one thing or multiple, and you have to kind of go one by one to try to treat them and figure out what's the main driver. In particular, our use of molecular testing, so sequencing people's blood or sequencing the bone marrow to find mutations that are recurrent and that seem to be prevalent in MDS, but also in other blood cancers and in healthy individuals, has really been a challenge, I think, as I try to integrate that into my clinical practice. We know that people, as we just live our lives, can acquire or have mutations expand in our bone marrow, so stem cells that have one or more mutations, and that over time, some of those can cause a true blood cancer. But often, especially when people have multifactorial anemia, you might find a mutation in clonal hematopoiesis and try to detangle it from the rest of their presentation, which can be a difficult challenge. And I think this kind of underscores it. So these are a number of studies all looking at how common is it if I sequence somebody's blood to find a mutation that represents clonal expansion. So, if I'm using the presence or absence of a mutation to say you have a blood cancer, how often am I going to find that? And the reality is, if you look deep enough, you can find it in almost everyone. So there's this line up at the top that's outlined in red. But they did very, very, very deep sequencing of patients who are otherwise healthy. And you could see that they had almost 100% of them, they could find some mutation in that population. So if we're using presence or absence of a mutation to define a disease, it becomes really difficult because many of these people will never have blood cancer in their lifetimes. So we do know a little bit about them, and I think that many of us who see MDS or see patients who have cytopenias are finding that they come with or that we do sequencing, and some mutations are worse than others. And so this is some data kind of giving a framework to think about that. A lot of this becomes trying to estimate what's going to happen to a given patient over the next years when you're following them. And we've known for a while that certain MDS genes, SRSF2, SF3B1, these are high risk for progressing, and then some genes that are more associated with clonal hematopoiesis might just stay in the background. And there's this tool that's been evolved using a large population-based data set. Now, just like any tool, it's not perfect, but it does give us a little bit of a framework to understand some of the risk factors that predict whether somebody's going to live with a clonal background for many years and never develop a blood cancer, and compare those to some people who will have high-risk features and that even within 2, 4, 5 years will have a risk of developing a blood cancer. And so I think as we develop these tools, we can try to understand patients at the highest risk of progression, and maybe even when we're 5, 10 years down the road, we'll be intervening earlier in their disease. All said, much of our work with understanding clonal hematopoiesis has really changed our understanding of how people develop MDS. I guess the thinking previously was that if you get exposed to some toxin, to some DNA damaging compound, it will cause a mutation in a stem cell. And that mutation that was caused by that exposure will then expand and cause a blood cancer. And clonal hematopoiesis has really challenged that framework, I think, because not only can that exposure cause actual DNA damage, but exposures that we have environmentally, time with aging, changes in systemic inflammatory markers, changes in what we live through over our lives, those can help pre-existing mutated cell expand. And so when we think about how people who have high exposure histories, like veterans, or in this example, looking at people who are first responders at the World Trade Center, they may not have been exposed to something that caused an exact DNA hit that then causes their blood cancer, but they may have had pre-existing clonal hematopoiesis that really expands because they were exposed to that environmental state. And so I think that this is a real-life example of what people might be exposed to if they are in combat or if they are in areas where they have a lot of environmental pressure on their body. What happens to those clones that they have pre-existing? There have been attempts to try to understand that in a veteran population. So this is kind of looking into a small group of patients, but how does Agent Orange seem to impact mutation profiles? And is it causing mutations, or is it helping a pre-existing clonal hematopoiesis expand because it's a kind of an environmental challenge for the body? I think that this is an example of what will eventually, hopefully, result in a bigger population of patients to understand how these exposures in service or throughout life might influence clones to then who develops blood cancer like MDS. And so when we think about the patient who is referred to us, he developed a worsening anemia over 3 months. So initial hemoglobin was about 8.5, and now it's dropped to 7.5. His platelets are still preserved, neutrophils are still preserved. Doesn't have any bleeding or nutritional deficiencies identified in a secondary workup. And then a bone marrow biopsy shows that he has an increase in ring sideroblasts. So here's a nice picture of these iron stain of these ring sideroblasts. Low blast count, 2% blasts, and panel sequencing was sent out and it came back with a mutation in the gene SF3B1. And so, I think now seeing this patient, I think this is a fairly common patient for my clinic as a new referral. How would you kind of risk assess this patient when you meet them?
Well, I think people asked in the beginning about the new scoring systems in IPSS-M, and I'm really glad that you're going to be talking about it. But to be honest, like in this case, I don't think the scoring systems help that much because I know this patient's low risk. I mean, and I think, at the ends of the spectrum, we kind of know it when we see it, right? Someone comes in with 18% blasts and 10 mutations. I don't have to plug that in. I know that patient's high risk. If someone has an SF3B1 mutation in ring sideroblast with one isolated cytopenia, I know that's a quote-unquote lower risk, and lower risk MDS is still something people die from, not necessarily with. So I don't really see the value in the system there. It's everything in between, which I guess you'll articulate more.
Yeah, absolutely. I think one of the challenges is how do we integrate this into clinical practice, and hopefully we can get some insight into at least how we're doing it, but it's an evolving thing. When when you're trying to meet somebody and describe these systems, they can be quite complex. Do you have a way that you tend to approach it with your patients?
Yeah, I mean, it depends on the patient. Sometimes showing them on my phone is not a good idea, but if I have a screen in my office, I can open up the MDS risk assessment tool, which, if you haven't seen, is a really nice tool we've built to try to make it visually understandable to patients. The input's a little complex for most of the patients, but all of you can handle it, and then the output, you can really see something that the patient can say, oh, this is where my risk sits on this curve.
Yeah, I think I have an example here, because there have been a lot of changes in the last couple of years. There have been changes in the diagnostic criteria. To be honest, like you mentioned about MDS with ring sideroblasts, some things have not really changed that much, and you know it when you see it type of thing. But there are some updates. There are two systems, and while that does create some conflicting nomenclature, overall I think that the two systems are pretty similar, and they draw upon the old criteria. Our pathologists tend to report both, but as far as creating a diagnosis of MDS, this tends to be the first step. The biggest takeaway, I think, is that we have a larger incorporation of mutation data, kind of reflecting our evolution of practice. In particular, the addition of TP53 mutated disease. So if you've lost both copies of TP53 through whatever mechanism, those patients really are difficult to treat. But overall, our minor updates that kind of have evolved with the field and how we diagnose MDS. But still, when I meet somebody, I'm trying to then prognosticate with them. Because the bigger question is what's going to happen over the next 1, 2, 5, 10 years as I follow you? And can we estimate that at the beginning? And then can we respond to any changes in your disease as it goes? And you're absolutely correct. There's a new online tool. It does have a lot of fields, so it is not something I can think of on the top of my head. So unless you're encountering one of these very low risk or very high risk patients that you can kind of see, for many of the middle of the group, it is helpful to plug them into the tool. I think another advantage of this tool is it can make estimates even if you haven't done a specific part of it. So if you don't know the mutation burden, if they didn't get sequencing at diagnosis, you can still input that was not done, and it will give you an error bar to kind of get a sense of their disease risk. And it comes out kind of like this. So when you plug in the risk of a given patient, using their blood counts, their chromosome testing, and their molecular testing, as well as blasts, you kind of get this curve. And this is the curve of all the patients according to their risk of progression. And you can see where your patient, this little blue dot, falls along the line relative to other people with MDS. And so it can kind of give you a talking point, a starting point, I think, of what to expect from your disease. How do we think about it? How does what is likely to happen influence how I'm going to treat you? Because for some people, I agree with you completely, people still, low-risk disease does not mean it is no risk. But the treatment goals may be slightly different than people whose disease is closer to acute leukemia. I guess just as an update to understanding all these prognostic scores, I still end up using quite a few of them whenever I meet a new patient. Many of our therapeutics were all developed in the old IPSS. And so the benefit of a lot of our drugs is based on their original IPSS risk. And it's not always clear whether those have the same impact when you get into a molecularly driven risk score. So I think that it can be helpful to talk to a patient about how risk changes and what that means for them. Overall, I think we have a better granularity for understanding how patients' risk is, but just being aware that any one score is imperfect, I guess. It's how you follow the patient and treat them that matters.
Great, Andrew. And in putting this score together, we pooled 3,500 patients with MDS across the world from about 40 centers. And the score, if you notice, it's binary. You either have the mutation or you don't. But as you saw in Andrew's presentation, it's not just binary, right? It matters what the variant allele frequency is. How many of the cells have that mutation? Which mutation is it? We've got that covered in a binary fashion. But the combination of mutations, we've only got this at a cursory level. And what's really a little spooky is there's probably something to the variance, which makes sense if you think about it. If you have a mutation at one point in the DNA versus another, it can change the structure of the protein and have different effects. So with that background, I'm going to get into some new developments. And I apologize ahead of time. I'm going to go very quickly. I'm happy to take questions about this, but this is a little different than a lot of presentations you'll see because I'm going to show 2 phase 3 slides with not a lot of the supporting evidence, so I can go over a lot of different bits. And I know you should be familiar with most of this, but I will reference the material and where you could find more. All right, so when we start here, we're talking about Robert, and we confirmed this by IPSS-M that it was just as I thought. It was low risk, but the patient has a transfusion burden of 4 packed red cells over 2 months, and now has a hemoglobin of 6.5. So would you call this patient transfusion dependent?
So yeah, it's a great question. There have been some changes in what meets transfusion dependence for the purpose of clinical trials. And sometimes clinical trials can be a little restrictive or not. But once a patient really starts to need transfusions on a consistent basis, even before potentially hitting 4 units in a 2-month period, that's when I'm thinking that this person has a transfusion dependence that we need to think about intervening on.
Yep, we're thinking iron overload, we're thinking intervention. And in 2020, all we had was really ESAs and Revlimid for the 5q minus folks. So this is where I'll introduce the first new therapy that a lot of you are starting to use in the clinic, and a drug called luspatercept. I was part of the development team for sotatercept, and the Europeans had luspatercept, so it was a little bit of dueling banjos, and they won. But the drugs are very similar, and they basically consist of this activin receptor that's kind of fused with the FC of the human IgG1, which basically floats around and scavenges ligand, thus squelching the capacity of the SMAD receptor to activate. And SMAD, as you may recall, is the negative regulator of late-stage erythropoiesis. So my mother-in-law's an English teacher. It's a double negative here where you're blocking the blocker, and that's kind of how the drug works. So we had really successful early studies, and in the phase 2 study, we had preponderance of deep responses with patients with ring sideroblasts. So there was a phase 3 study that you're probably very familiar with called the Medalist study, and the Medalist study randomized patients with ring sideroblasts who are likely not to respond to EPO or who have failed EPO. And when I say likely not to respond to EPO, I mean a serum EPO level of greater than 500. And they were randomized 2-to-1, which we felt was the merciful thing to do because we already had such a strong signal in the early clinical study. And this is the result with the primary endpoint of 8-week transfusion independence. And you can see that the transfusion independence was superior luspatercept after EPO failure to placebo, which was not unexpected, and maintained for 12 and 16 weeks. And I'll show you some long-term follow-up in a few minutes. And this was true no matter how many transfusions people had before, but it's important to note that and this is kind of like, the common sense piece. Well, the more damaged in your bone marrow is, the more failure you have, the less likely the drug is to work. And that rang true, where the more transfusion dependence you had, the heavier transfusion burden patients had less of a chance of responding and doing better with luspatercept than placebo. But those patients with low and intermediate kind of transfusion dependence did fairly well. So this study led to the approval of luspatercept, and it's used in the second-line setting in patients with ring sideroblasts. But we asked the question, wait a minute, what about patients who don't have ring sideroblasts but have low-risk MDS that we treated in the phase 2? Could those patients benefit from getting the drug? And 2, well, this really worked well. Is it better to use it up front in ring sideroblast patients? So the COMMAND study was designed, and we can talk about the design a little bit, but basically lower risk MDS patients who were transfusion dependent, not the high transfusion dependent patients, the lower transfusion dependent patients who were unlikely to respond to EPO, because otherwise you'd be setting the EPO arm to fail here. And they were randomized to either luspatercept with a gradual titration capacity from 1 mg per kg to 1.75, and I'll underscore 1.75 is the acceleration of the drug in MDS, and I can't tell you how many referrals I get of patients who go from 1 to 1.33, because that's the dose escalation in patients with beta thalassemia, and there's some confusion about that in the community. And then the patients with EPO started at kind of a low dose and then went up to this 1,000 units per kilogram, which is kind of what you guys are used to seeing, 60,000 units a week, which is kind of where we max out. And then we looked at the response every half year or so. And in the COMMAND study, the patients who received luspatercept just did better. I mean, there was more transfusion independence, as you can see here, and it's statistically significant, than the patients who received EPO up front. If you look across subgroups, this was true across subgroups in the patients who had really, 200 to 500 serum EPO level, as you'd expect, luspatercept would do a lot better. In ring sideroblasts, as you expect, they do a lot better. But in the patients with ring sideroblast negative disease, there was clearly a benefit to luspatercept, but it wasn't really a benefit over EPO. Likewise, the SF3B1 mutant, consistent with the ring sideroblast SF3B1 mutant pairing that we see a lot of the time, didn't do all that much better. But what's really important about this is the transfusion independence and the duration of the transfusion independence. The patients that went, I mean, everybody ends up at the same place, but we're talking, impacting natural history, not biology, by treating people and making them less likely to have to get transfusions. All the complications of transfusions, which we know can impact survival, but also quality of life. And the median transfusion, duration of transfusion independence was over 2 years in patients with luspatercept, so this is really impressive. Now, if you stratify this on ring sideroblast positive and ring sideroblast negative patients, the patients who had ring sideroblast, as expected, did far better on luspatercept, but there's no statistical significance in the RS negative. It looks like that luspatercept arm is breaking away at the end, but there's not enough events there. So those curves are overlapping. So what does this tell us, the COMMAND study? Well, luspatercept is superior to EPO in this setting with respect to achieving transfusion independence. We know we can now use this across the board, and the approval that was just granted in August was a fairly broad label, so you can use this drug in patients who have never even had EPO. Well, what hasn't been tested, though, it's never been tested whether people get EPO followed by luspatercept versus luspatercept followed by EPO. So, if you got patients who are likely to respond to EPO, it's probably just fine to give them EPO. But we learned a little bit more about a little more experience in this additional phase 3 study of luspatercept and some of the safety profile, which I'll show you in a minute, which made us feel a little more assured. And then we have long-term data, which will help us kind of get a better sense of that point I made a minute ago about sequencing these drugs. Okay, Andy, so you have this patient, Robert, that you were telling me about, and I just gave you this data from COMMANDS. What do you think you should do with this guy up front?
Yeah, this is an evolving area. I think we're all learning how to integrate this data. When I look at COMMANDS and when I look at Medalist, my takeaways are luspatercept is very active. If somebody needs a response faster, luspatercept may offer that. And luspatercept can last longer, but it has less of an impact in late phases of disease. So when people are really heavily transfusion dependent, I think it's more challenging. And so for people who have MDS with ring sideroblasts, it really is a question of, do I give them a chance to see if EPO gives me a little time, or do I just jump straight to luspatercept? And I think that the big takeaway for me is management of anemia in MDS is no longer just set it and forget it. You can't just start somebody on EPO and kind of hope that things go okay for as long as possible. if I were to start Robert on EPO, I'd probably make sure that his transfusion needs went away, and if they don't, switch over to luspatercept quickly, which is a little bit of a change, a little bit more active management for these patients than I might have done in the past when I only had one drug. And so I'd still talk to him about the possibility of going on ESA. It is tough because we don't know if I could use it down the road. But I definitely wouldn't let him linger on it if I did try it.
Yeah, it's definitely give us a lot more flexibility, which, it's nice to be able to, enter a gunfight with more than a sword, right? So, you have a couple of weapons there. Okay, so if we do start on luspatercept, then what do we have to think about with respect to safety and dosing? Well, in the Medalist study, we were a little concerned because we saw a lot of fatigue. And if you've given this drug, there was, in the Medalist study, 40% of the patients had grade 1, 2, at least some fatigue and that's a big number. Most of that was grade 1, 2, but it was enough that it was enough to take some of those patients off study. So entering commands, we were kind of saying, well, we're going to see that same level of fatigue, and we really just didn't. Fatigue and asthenia were much lower. I will say that just like the clinical studies, if you can get someone through that first month, it does go better. Of course, that's a bias. If you can't get through the first month, you're likely to have more, your fatigue is likely to be too much. And that is something to kind of keep your eye on. We're not sure of the mechanism of that yet, but it's not an anemia-related fatigue. That's independent of their response. We do have some cytopenias, but we think this is consistent with placebo and, the progression of the disease. Everybody who's on this drug, though, could have an increase in blood pressure, which, you're going to have to watch. And most of the time I manage through increases in blood pressure. I say that, if I'm using 2 drugs or less, I can manage. If it's more than that, I send to the cardiologist or their internist to manage. But, the expectation that they might need more antihypertensives with a growing dose is real. Okay, so for the remaining 10 minutes, I want to talk a little bit about, what's next. In high-risk MDS, there's been a lot of excitement that you've probably seen at ASH or ASCO with some of the disease-modifying agents. Unfortunately, the magrolimab didn't pan out as we had thought, and I have some thoughts on that if you want to ask at the end, because I do think it's an active drug. But we still have to hear about TIM-3 and venetoclax and MDS, which does look promising. And then there's a variety of new agents looking at lower risk MDS and even late stage CH. And if you look at the things that we do for lower risk MDS, once patients fail or are failed by EPO and luspatercept, there's not much left. If they're not a 5Q- patient, they're not going to respond to lenalidomide. HMAs are the backbone of our therapy for high-risk MDS, but in my experience, in low-risk MDS, after EPO and luspatercept failure, they're not particularly useful. So we really need agents to address this transfusion dependence, which I've already showed you early on in the talk, is an independent risk factor for survival. So, Robert, let's assume Robert received ESA instead of luspatercept, and his transfusion requirement went down. And he was responding very well, but now it's 14 months later, and his transfusion requirement's gone back up. What do you make of this? Do you just keep him on EPO, or?
Yeah, I think that this is a pretty common scenario where you get some benefit for a little while out of EPO. Sometimes that can be a really great transfusion-free period, but recognizing that the need for transfusions, unless there's some other explanation, GI bleeding or a viral illness or hospitalization or something that you can explain the worsening. Historically, I think we used to leave people on EPO and assume that they would do worse if they weren't on it. I think that here is really where it should be a trigger for us to change therapy, and that they really have been failed by the EPO at this point. Yeah,
it's analogous, right, to I tell patients, if with acute leukemia, you induce and you're in remission or you're not, and in these chronic myeloid diseases, it's kind of like the team of horses. You have the bridle and the reins, and some of the reins may bust through, but you still have some. So you're kind of keeping this to a canter rather than a gallop. But the more reins we have, the less that that theory works, and the best it is to kind of look for the next available therapy. So this is the exciting thing for us. We'll talk about some of these options kind of coming down the pike. So the long-term data for luspatercept is very promising. The patients that had at least a 50% transfusion burden reduction, and the low transfusion burden patients is pretty high, 60% of the patients. And the patients had 75% transfusion reduction, a little lower, but still impressive. So we published this last year, and we're pleased with the long-term follow-up so far. We'll be interested to see what this looks like long-term follow-up of commands, which of course is a little bit different study population. So these are the two survival curves from the ESA-001 for azacitidine and the cancer paper from Hugo Katarjan, now published 18 years ago, and leading to the approval of both of these drugs. But as I said, at the doses we give them, they're fairly cytotoxic and can cause more problem than good in lower risk MDS, and really don't fix the anemia, especially when these patients start to develop a lot of transfusion dependence and fibrosis in the marrow. But there is an idea to kind of use like a little bit of dose, and we attempted this. This was presented this year at the MDS Foundation International Congress in Marseille, where my partner and we developed this oral decitabine sidazirine. Guillermo Garcia-Manero presented his metronomic dosing data, and you'll notice here, if you look, this is sidazirine 100 milligrams, same as the Incovi, which is available to you, but the decitabine dose is not 35 milligrams, but 5 milligrams. So the idea is to give a low-dose oral decitabine or sidazirine over a longer period of time to see if you can impact transfusion dependence. And this is early data, but you can see in a few patients it worked, and we're trying to see. This is a swimmer's plot with the dots indicating this transfusions. But we're still early going, but maybe this is a opportunity. And because it's oral, it doesn't make a lot of sense to have people come in and get parenteral decitabine 10, 15 days in a row. But maybe with an oral drug, we can get away with this, and if we use metronomic dosing, with this lower dose, it might be safe. That's all I'll say about that. And I'll move on to imetelstat, which this has been a long, very now gratifying, because this is looking like it's getting close to approval, but just a long development story. We first used really high doses of the drug and had some non-heme toxicity, which were all dose dependent, and we've solved. And I'm going to show you the phase 3 data, go right into it in a minute, but just let me briefly tell you what this drug is. Imetelstat is a telomerase inhibitor, and malignant cells have continued upregulated telomerase, which leads to this apoptosis, necroptosis, and necroptosis is an inflammatory condition. The cells break open, all of these damps and inflammatory cytokines are spilling around in the cytoplasm, or in the niche rather, and they create kind of more inflammation and more genetic change, and this is kind of the cycle of lower risk MDS. But this is particularly potent in lower risk disease in early trials, so a phase 3 study was conducted called the iMERGE study, and we just had this accepted to Lancet, so you'll see it in press soon, but I'll show you the data, which has been presented by a few different people, Amir Zaidan and Uwe Platzberger over the past year or so. Basically, it's a similar population to the medalist, or to the command study rather. We took lower risk patients who were either ring sideroblast positive or negative, and they were unlikely to respond to EPO, and they had transfusion dependence, more than 4 units in this study, defined as more than 4 units over 16 weeks. We excluded patients who were going to respond to lenalidomide, the 5Q people, and they couldn't have had len or an HMA. And they basically were stratified by high transfusion burden or low transfusion burden, similar to the medalist and command study, and randomized, as you can see here. And the take-home message from this study is that the primary endpoint of 8-week transfusion independence was superior for imetelstat, and this was maintained at 16, 24, and even 52 weeks. We did lose responses. Only 13.6% of the patients had a transfusion independence at a year, but that's compared to 1% or 2% in the placebo arm. So, we're pretty bullish on this, and what's really exciting about imetelstat is that we think it modifies disease. So luspatercept, we're not really sure if this is modifying the malignant clone. There's no evidence that the that the VAFs of the mutations go down or that the process is stopped. We're helping with the anemia because we're blocking the blocker of late-stage erythropoiesis, that SMAD interaction I told you about earlier. But imetelstat is actually changing the hematopoietic stem cell insofar as we see reductions in the VAF. So the mutations that are present at the beginning of the trial, especially SF3B1, tend to relent when the patients respond. We're not sure we understand that exactly, but that's very that's promising. As a physician scientist, I'm really kind of happy to see that. Now, what about the duration of the response? Well, we lose response. I showed you only 13% of patients transfusion dependent at 1 year, but the patients who do respond can get some really nice 2-year duration of their transfusion independence. And this adds one more kind of bullet in the gun with respect to taking care of low-risk MDS patients who are transfusion dependent. Now, the big difference with imetelstat is this causes a fair bit of heme toxicity. And, as MDS doctors, we're kind of used to this, right? We give HMAs and everybody's counts get worse before they get better. So this wasn't too big of a deal to deal with in the trial. But, if you're giving someone an infusion and then sending them home in a month, this is not luspatercept. It is a drug that may cause some significant cytopenias leading to discontinuation in extreme cases, but more often dose holds or dose modification. So it's important that in the first couple cycles at least that you're checking people's CBC weekly or even more in some cases to assure you don't end up with a bottom out of counts and in between cycles. So before we get to questions, I just want to summarize a few things from our presentation. Molecular genetics are now not optional. It is standard of care for patients with MDS and really critical. I mentioned that you know it when you see it, ring sideroblast with SF3B1 mutation, but there's a small number of patients, about 15% of those SF3B1s that have TP53 mutations, and they do not behave the same way, and they quickly develop a clonal evolution, and that comes out if you look at IPSS-M in the beginning and you have next-gen sequencing. If you don't have it, you're not going to see that. I think that you should do that at diagnosis, but anytime there's a substantive change, as Dr. Bruner said, I mean, it's difficult because sometimes these people, they're 75 years old, they could have angiodysplasia and have rectal bleeding, and their anemia can appear to be getting worse on age, and really it has nothing to do with their bone marrow. So you do have to be careful, but if they have verifiable loss of response, that's a time to look again. You can look at all of these scoring systems, and the Sankey plot that he showed is really informative because the patients with low-risk MDS, and I think the graph you showed was IPSS-1, IPSS-int1, and you all remember from the 90s Corey Cutler's paper where intermediate 1 patient shouldn't go to transplant, intermediate 2 should go to transplant. At least that was kind of the estimate of what we should do with these people. Well, those intermediate 1 patients, they now stratify into really high-risk patients on IPSS-M or really low-risk patients. So it's really helpful for those people, as I said in the middle. There's a lot of new therapies in MDS. This has been my career's work, trying to develop new therapies for patients who don't have them. And it's very gratifying now after 15 years of kind of a crickets to see a lot of things starting to actually get purchased, where our wheels have been spinning. We're really starting to get purchased now, and hopefully you have fun taking care of them because there's a lot more things we can do, and that's gratifying when we have more than a hand on the shoulder and our empathy. Hopefully this gives you a sense of how to set treatment goals to achieve the benefits that you hope to receive with your patients. Really appreciate your attention, and we're happy to take questions. Thank you. Have you ever used low-dose single-engine ESA and low-risk MDS? I have, off-label, and I was involved in the ESA, oral ESA CC486 studies years ago. We tried to get CC486 into lower risk. Well, first we had tried higher risk MDS. And I will tell you that the Quasar study showed that drug is beneficial in that very small subset of patients who kind of can't get their full consolidation. But that drug is not equivalent to azacitidine. It's a very different drug. It's active, but it's very different. And we learned this by using all kinds of dosing, trying to overcome the cytidine deaminase in the gut that would deaminate the drug as we took it orally. So that was the philosophy with the CC46, as opposed to the Incovi Aztec 727 approach, which was, hey, let's put a candy coating on that chocolate so that we can get it through the metabolism and it appears in the blood equivalent to the parenteral dose and have equal pharmacokinetics. So I have done it before with kind of middling success, I had a little more experience with the oral ESA, but I'm not sure at this point I'd recommend that, at least in the very beginning, because you have so many new options that are more likely to work and probably with less toxicity. So this is a question, I'll ask Andy to answer this one. So when do you do a bone marrow biopsy in asymptomatic elderly patients who you think have MDS?
Yeah, it's a great question, especially with these gene sequencing panels. There are a lot of efforts. Can you get around bone marrow biopsy? I think for a full picture, we're still doing, the bone marrow biopsy is still kind of integral in that diagnostic step. And especially anyone who's older, who has an unexplained cytopenia, the chance of them having some clonal process is relatively high. So if anything, we probably underdiagnose patients by not trying to get that last step of testing. So mutation testing has been great. It can be done on the blood. It can help us, but I think it has not yet obviated the need for a bone marrow exam.
Yeah, I agree with that. It's funny, in my practice, I have a CHIP clinic, which I started in 2018, and at first it was all the solid tumor patients who had like a random clone that they found, but now I get 23andMe people, I get people who just pay, who have a slight anemia. I got people who want to do, I'm billing as a hematologist for cardiac risk evaluation, this is kind of where we're at, I think if I have the benefit of knowing someone has, high VAF mutants or combination, my trigger to do a bone marrow biopsy is a lot quicker than it might be otherwise. So there were questions about data on MDS and Gulf War veterans. I'm one of those, so I'm kind of particularly interested in this question. We don't, but the Million Veterans Project, which I'm sure many of you are involved in, is going to be really a monumental step forward in understanding pathogenesis of disease for specifically veterans. And hopefully, at Vanderbilt, we're a data center for this study, and we're very interested in kind of seeing how that turns up. Yes, sir.
Do we have any evidence that it actually improves overall survival? When is the starting chelation? Mayo Clinic said something some years ago about 100 units. They didn't think there was a problem until you got to 100 units. Obviously, we know that if you get hyperferritinemia, though, you probably do have a shorter survival. But are we actually benefiting that?
Yeah, so I'm going to let Andrew answer that, but I'm going to start by saying that what we heard years ago is wrong. So go ahead, Andrew.
No, for sure. I think that it's a tough thing to study. The best study is probably the Telesto-2 trial that looked at chelation and had a combined endpoint, which includes survival, but also included a number of cardiovascular endpoints. And so chelation did reduce the number of events in that study, but it's a mixed bag, and some of that is iron overload, some of that is survival, some of it's just complications of chronic transfusion. So if I prefer to use a therapy to take away their transfusion needs and try to push that out. Somewhere in the 1,000 to 2,000 ferritin range, I tend to. I don't use a specific cutoff for red blood cells. It's usually the patients who have an anemia that they're going to have it for a long time. I'm not going to fix this. It's going to be years of therapy. You're going to get transfusions during that, and somewhere in the 1,500 is probably my average ferritin, but it's usually more. By that point, they've gotten a lot of transfusions. We know that they're stable, and it's more to facilitate their long-term outcome.
Yeah, I think there's I do it earlier, and you're going to see this kind of like debate because we don't have good data. I tell my fellows it's the evidence-free zone, the EFZ. We don't know exactly what the right number is, but I try to think about it contextually. So if I have someone who is going to be a transplant candidate, and this gets up to a couple more questions on the list here, I got to be thinking, I got to make sure their liver's good and they're not, iron overload, because that's an independent risk factor for death with transplant. And so, why do you transplant low-risk patients? Well, let's talk about that a little bit. If you have an 85-year-old who's got low-risk MDS, the goal is to have an increased quality of life, and this is something that you hopefully can die with and not from. But if you have a 45-year-old or a 50-year-old, then that patient is not going to make it to the life expectancy they should without a stem cell transplant. We're thinking more, and IPSS-M is helping, but we're thinking more about transplant earlier, but we have to evolve. Like, our guidelines aren't even there. We can't get insurance to cover low-risk MDS, and frankly, we shouldn't be transplanting a lot of these people. But some of these younger patients, and I will tell you, anyone under 60, I do bone marrow failure screening on, because you shouldn't get MDS in your 50s or your 40s. And I've picked up a lot of germline disorders and telomeropathies. And that helps us not only to know they need a transplant, but it helps us to know that the transplant preparative regimen should be very different. Because if we get a dyskeratosis patient, a typical dyskeratosis patient, high-dose therapy, we can really mess them up. Here's a question. I like this one, Andrew. I'm going to let Andrew answer this because I don't want to. So, would you ever consider combining ESAs with luspatercept?
So I have done this. And there is some data to guide it. It's all retrospective at this point. It tends to be people who have responded to ESA and then responded to luspatercept. And then when you've lost the response to luspatercept, you can sometimes salvage them by combination. And I've had some patients benefit. I think, to your point about when faced with what to do next, and if there's not a lot of options, HMA therapy can be kind of a unpalatable option for a lot of these patients, especially if their only problem is still anemia. So that's the setting where I've tried it, and you do get some responses. Blood pressure is a little bit more of an issue, though.
Yeah, I would say the same. I think in the VA, one thing I've learned, it may take longer to get on formulary, but you have a lot more freedom when you have things on formulary. And in the private market, it's sometimes you can scream in a peer-to-peer, but you're never going to get both of those drugs paid for. So that's more of the issue in the outside of the VA. So there were questions about, in your experience, how rapidly can patients become transfusion dependent, and what time interval should we have in mind when monitoring patients? So that's a mixed bag, right? I think that we have clues in next-gen sequencing of which patients are going to develop acute leukemia, and Andy and I, kind of seeing a lot of this day after day, get a sense of, they have high VAF of UTA of 1. I know this patient is not only going to be at high risk for leukemia, but they're going to have more transfusion. If they're already anemic, they're going to be transfusion dependent quickly. You get kind of a sense of that gemisch. But really, just like the scoring systems, the C index is still only 75%. So these are our kind of best bets on, and like I tell patients, there's no you out there. There's 1,000 people kind of like you, and I'm trying to give you an idea how those 1,000 patients did, and to project how you might, but you might not do like that. You might do a little bit differently. So it's really kind of all over the place. There's some questions here, Andy, about the academic versus community HCPs using the new diagnostic, prognostic, and response criteria tools in daily practice. So like IPSS-M, what's the difference between how you might use it and how it might be used in the community? You can even argue between us, we probably use it differently. I think we're still evolving in how we interpret it. I think that one of the challenges is that of transplant decisions. I think that the IPSS-M and understanding molecular risk has really enhanced our understanding of who's not going to just have quiet disease, and you figure that out along the path with them, but it gives us a preview of what's ahead, and so that sometimes can be helpful to set expectations with patients after they're diagnosed. But for therapeutic intervention, especially in older patients, I'm often thinking back to the IPSS. If I've got somebody who's only got anemia, they have higher mutation risk, but their only problem is anemia, and they would have been intermediate 1 by IPSS, and now they're high risk by IPSS-M, I'm often still therapeutically leaning back to the scores that were used for the original trials. And so Maybe your ears are a little bit more peaked, but you're using the earlier therapy.
Right, exactly. And so I think that is one of the areas of evolution where when we use these, no one tool is perfect. and we have to kind of also think about how the patient contextually, what they need. So it's an evolution, but I think it's a great new tool, and it definitely, exactly as you said, people who have high mutation risk, you're maybe watching them a little bit closer.
Well, with that, we'd really like to thank you for your attention. Hopefully you got something out of this, and we'll go ahead and end the program before they gong us off the stage here. Thanks. Have a great day. Enjoy the rest of the conference.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/HWU860. This activity is supported through an educational grant from Bristol Myers Squibb.